Word. Okay, so this is the case study that we're going to talk about. And so this is a 26-year-old female of Latin descent presenting to the emergency department with lightheadedness, generalized weakness of the left lower and upper extremities, and a sudden headache after completing a 2.5-mile sprint. Reports some nausea but no vomiting, thinking she was dehydrated from her exercise. She drank about a liter of water and self-administered 500 milligrams of acetaminophen for pain with no improvement. She reports the symptoms began approximately at 9 o'clock, no significant previous medical or surgical history, takes an oral combined hormonal contraceptive, occasionally drinks 3 to 4 glasses of wine a week, and vapes with e-cigarettes daily. Continuous cardiac monitoring initiated per protocol. Heart rate is 99 beats per minute. Blood pressure is 160 over 100. She is awake and alert and can make her needs known. Voiding clear yellow urine. Abdomen is soft with bowel sounds in all quadrants. Reports increasing numbness to the left side and the lower extremities. So in reviewing this particular clinical scenario, the question is, which of these findings require immediate follow-up? And so you're going to answer, I'm going to launch the case here. And if you just answer it, then we'll discuss it. Okay, so wonderful. Let's take a look at this. Which of these findings require immediate follow-up? Now, letter A, lightheadedness. This is going to be one of the things that we will be looking at whenever we have disruptions of blood supply into the brain. So like a myocardial infarction, for example, a disruption of blood flow to the brain is a medical emergency and requires immediate and intensive attention. So lightheadedness would be a correct response. Okay, so how about general weakness of the left upper extremities? That also is going to be a very significant finding, and therefore I think that it also needs immediate follow-up. And that headache that is sudden is also going to be very, very significant, as it is going to be a manifestation, perhaps, of a cerebrovascular accident. The administration of acetaminophen, the glasses of wine a week, the heart rate are not significant at this time, but a blood pressure of 160 over 100 probably requires a follow-up because that's elevated. So we said that any blood pressure that's above 129 is going to be something that is significant and therefore demands attention in a medical situation such as this. Okay, so let's go to question number 2. We had already looked at the admitting note, and now this one is that for each finding, click to specify if the finding is a risk factor or not a risk factor for ischemic stroke. Okay, so we're being asked this question. Okay, so let's take a look at the options. Combined hormonal contraceptive. This is indeed a risk factor for the development of stroke. Um, Whenever we have individuals that do have oral contraceptives, this increases the risk not only for DVT, but also for stroke. So, combined hormonal contraceptives in particular is a birth control that contains estrogen to prevent ovulation. And therefore, this is going to impact the coagulation systems and increases the risk of blood clots or stroke or heart attack. So, that is a risk factor. Now, how about alcohol? Now, alcohol, which is 3 to 4 glasses of alcohol a week, this has come into light as far as whether or not it actually is a risk factor or it actually is a something that prevents the development of stroke. Now, the idea here is, or the evidence have shown, that if you drink 1 glass of wine or alcohol per week, per day, it is not going to be a risk factor, but rather it actually protects you from the development of stroke. So once a day is okay, but more than that is going to increase your risk for heart attacks, for stroke, or other disease processes that um, is related to alcohol use, such as liver damage and so on. So drinking 4 glasses, 3 to 4 glasses of alcohol a week means to say that it's less than once a day. So this is not going to be a risk factor. All right. And how about vaping cigarettes? Well, cigarettes is going to contain nicotine, and therefore, as an active ingredient, it increases the risk of the development of blood clots, as well as stroke or heart attack, while using estrogen. So the fact that she smokes and at the same time is an oral contraceptive, this increases her risk twofold. And completed a 2.5 sprint on the treadmill. This has nothing to do with the development of a stroke. And then, of course, Latin descent. Uh, Individuals who are at risk actually are African Americans and some Hispanic Latino Americans. They have been found to have a higher stroke incidence and mortality compared to Caucasian Americans. So that would be a risk factor. Okay. So tomorrow we will be talking more about the other risk factors that are associated with stroke. So let's now go to question number 3. And question number 3 is now we have a head CT, which shows that the patient is having an ischemic stroke. So what would be the top priority for this patient? What would be the top priority? Okay, I think you got that correctly. The important thing over here is restoring cerebral tissue perfusion. As you recall, whenever we have an interruption of blood flow to the brain because of either an embolic or a thrombotic event, it could lead to an ischemic stroke. And I just want to pause over here to tell you that there are different kinds of strokes, obviously, but one differentiation is the etiology. So if a stroke is going to be caused by occlusion of an artery, then this is going to result in what is known as an ischemic stroke. An example of that would be if there is thrombosis that occurs in one of the major cerebral arteries, then this is going to cause ischemic stroke. The death of the tissue occurred as a result of interruption of blood flow to the brain. The other kind of stroke, however, is going to be a hemorrhagic stroke. And hemorrhagic stroke is different in its pathophysiology compared to ischemic stroke, in the sense that in hemorrhagic stroke, there's going to be a bursting or a rupture of an artery in the brain, and therefore leading to tissue death of those areas that are going to have an interruption in their blood supply. So those are the two kinds of stroke, and therefore restoring cerebral tissue perfusion would be the appropriate response over here. Okay, let's go to number 4. So now at 11:30, a 20-gauge IV was placed in the right and left antecubital per protocol, and blood work were drawn and results returned. And the laboratory shows you the following things over here. So the glucose is 186. And as you know, in the new generation NCLEX, the normal values are now going to be displayed for you as far as the case studies are concerned. So if we take a look at this, this is obviously elevated, isn't it? Okay. And the hematocrit, which is for females, is going to be 35 to 47. So this is elevated. What does hematocrit tell us? Well, it tells us about the hydration or the relationship of red blood cells as well as the fluid component of blood. And therefore, the higher it is, that means to say that the more concentrated the blood is. So what would be the risk if your blood is concentrated? That means to say that you will have more propensity to the development of blood clots. So that would be a something that is significant. The hemoglobin is going to be okay. The platelets is going to be a little bit elevated. And then the PT is 13.5 seconds, which is also elevated. Now the orders are alteplase, and alteplase, whenever you see the suffix ase, that means to say that this is an enzyme. And in fact, this particular drug, alteplase, is a thrombolytic agent. In other words, it's going to lyse or it's going to dissolve existing blood clots. So remember that thrombolytic agents are different from anticoagulants. They're not one and the same, okay? Thrombolytic agents dissolve blood clots. Anticoagulants prevents blood clots. So those two things are very, very important. So we're giving this patient alteplase, and we're going to give a bolus of labetalol. What is labetalol? Whenever you see the suffix olol, that means to say that this is a beta blocker. And beta blockers are actually given for patients who are suspected of having a myocardial infarction or even a stroke in order to decrease cardiac demand for oxygen, or in this particular instance, the labetalol is going to decrease the blood pressure. So that's why this labetalol is given. And then, of course, this is given to maintain a systolic blood pressure of 140 over millimeters, but less than 185, and a diastolic of 80, but less than 110. Okay. Now, what are the things that you notice over here. Whenever we have brain injury, we always want the blood pressure to be higher than normal. So if you notice over here, the order was to keep the systolic blood pressure above 140 millimeters of mercury. Why do you think there is a need to maintain a higher blood pressure in these patients? Well, the problem is, or the reason for that is this. So let's say that this was the brain tissue, and this is now the blood vessels. And because of the injury to the brain, there is ischemia into the brain. There's now going to be inflammation that occurs in the brain. Okay. So what happened now to the size of the lumen of the blood vessel? It has now decreased. So if I draw the blood vessel like this, it's going to be like that, right? You would need to require greater pressure to perfuse this area. If you're going to have a very low blood pressure, the blood is not going to flow through this obstruction over here. And that is the reason whenever you have patients with head injury or head trauma or head pathology, such as in stroke, we usually keep the blood pressure higher. So in this particular instance, the order is above 140 millimeters of mercury, but not more than 185. Okay, so we don't want it too low, but we don't want it too high either. All right. So the reason again that we want it higher is in order to maintain cerebral tissue perfusion. So that is the important things about these two drugs, the alteplase and then the labetalol. So again, anytime you see ACE, it is an enzyme, and usually this enzyme, in this particular instance, is going to be used as a thrombolytic agent. So alteplase, streptokinase is another one that is going to be commonly used in order to use as a thrombolytic agent. Okay, so let's go to the question now. The nurse reviews the healthcare provider's orders and plans to administer alteplase. What additional assessment data should the nurse obtain before administering alteplase? All right, would you please answer? Okay, very good. So let's take a look at this answer. This question. So as I said, thrombolytic therapy, which alteplase, or also known as recombinant TPA, is used to dissolve the blood clot, and therefore it is going to be very effective for patients with ischemic stroke. Now, the dose usually is going to be dependent upon the weight. And so when a patient arrives with a suspected stroke, we actually weigh them because we need the actual weight. We do not want an estimated weight. We want an actual weight so that the dose is going to be calculated correctly. And of course, whenever we are going to give alteplase, there are several considerations that are going to have to be met. And the first one is that we want to start the thrombolytic therapy within 3 hours of, of the onset of symptoms, because this is going to limit the amount of magnitude of the damage to the brain. So we want to give it within 3 hours of having the symptoms. Now, there are obviously going to be contraindications because this is going to be thrombolytic agent, meaning to say that it will dissolve any existing blood clot. So it would not be good to give it to patients who are pregnant. And so this would be a contraindication for the use of a thrombolytic agent. Blood glucose. We don't want the blood glucose to either be hypoglycemic or hyperglycemic. We want to make sure that we control those first because of the fact that it also increases the risk of other complications. So blood glucose of that's greater or lesser than 50 milligrams per deciliter, and no major surgical procedures within the past 14 days for obvious reasons, because if they had surgery, then the risk of bleeding is going to be great. Recent international travel, and as well as a serum pH is greater than 7.35, are not contraindications, because we know that a normal pH is anywhere from 7.35 to 7.45. So that should not preclude the use of a thrombolytic agent. Is it important to confirm the onset and the time frame of the symptoms? And the correct answer to that is yes, because you remember that we want to make sure that we give it within 3 hours of the onset of symptoms. So this is going to be a correct response. Serum potassium that's greater than 3.5, well, we know that potassium is going to be anywhere from 3.5 to 4.5. So this should not be a problem at all. And can safely ambulate to the room. This is not a contraindication or is relevant for the use of a thrombolytic agent. But the client weight is going to be very important. As I told you, we actually have to weigh the patient with a weighing scale. There's not going to be a guessing game, because the pharmacy will need that in order to calculate the right dose to be given to the patient. Okay, so let's go further to the case. And now we're in question number 5. And the question in number 5 is this. For each possible action, click to specify if it is indicated or not indicated after having given alteplase. Your answers? Mm-hmm. Okay, so let's take a look at these options and see whether or not they're indicated or non-indicated. So whenever clients receive thrombolytic therapy, they're never going to be admitted into a regular floor. They have to be admitted into an intensive care because they require continuous cardiac monitoring and, of course, close observation for bleeding. So the number one complication whenever you're giving a thrombolytic agent such as alteplase is going to be bleeding. And therefore, oral anticoagulants are going to have to be withheld for the next 24 hours. So this is going to be indicated. So oral anticoagulants are withheld for the next 24 hours. Arrange for an inpatient admission to the medical surgical unit. Now, I told you that patients who have received these drugs are at high risk for bleeding, and therefore they should be admitted into the intensive care unit. So this is not going to be indicated. Now, assess and monitor vital signs for intracerebral hemorrhage. While this is one of the complications associated with the use of thrombolytic agents, the possibility of intracranial bleeding, and therefore the patient's neurological signs are usually checked every 15 minutes for the first 2 hours, and then, of course, every 30 minutes for the next 6 hours, and we can do it every hour until 24 hours after the treatment. So this has got to be a indicated intervention. All right. Insert an indwelling catheter to record urine output accurately. Whenever you have had a thrombolytic agent and you do a catheterization, what's going to happen is that it increases the risk of bleeding. So insertion of NG tubes, Foley catheters, or any type of IV devices like maybe an arterial line is going to have to be postponed for the next 24 hours. So this would not be indicated. We do not want to do this because, again, it increases the risk of your bleeding. Consult with hematologists to increase the client's PT and INR levels. Well, actually, we don't need to do this because of the fact that the PT and INR levels are not going to have to be increased, and therefore this would not be indicated. Keep the client NPO until a speech and swallow evaluation is completed. Whenever you have a patient with stroke, one of the major things that you have to do is to observe them for aspiration. Whenever they have difficulty in speaking or any time that they have dysphagia, there is a risk for them to aspirate. And therefore, we usually keep the client's NPO until such time that a speech therapist conducts a swallowing evaluation. So this obviously is going to be something that we would have to do. Okay. And then, of course, monitor serum glucose level to prevent complications of a stroke. As I said, we want to maintain a normal or close to normal blood sugar. And usually our goal is anywhere from 140 to 180 milligrams per deciliter of blood sugar. So that is our goal in order to maintain your metabolic activities in the brain. So we don't want hypoglycemia. We don't want hyperglycemia either. Okay? All right, so let's go to the progress now. And it says over here that at 11:30, no, 12:30, the patient is now transferred to the critical care unit. Head CT shows ischemic stroke, and we have the same laboratories. Oh, and the progress notes are going to be the following. Let me just magnify this. So day 2 at 8 o'clock, the client is awake, alert, and oriented to person, to place, and time. The heart rate of 98 beats per minute, sinus rhythm, blood pressure 128/86, and afebrile. Bleeding and fall precautions continued. Instructed to use the call bell for assistance for ambulation. Provided stroke education and expected outcomes after a stroke review. Health, risk factors, signs and symptoms, early interventions, follow-up care, and apixaban at discharge discussed. Advice of the speech and swallow test to evaluate the motor function of the oropharyngeal. Educated on the adverse effects of alteplase and increase risk for bleeding. Okay, so now let's go to the question. Click to specify whether the statement indicates an understanding or no understanding of the teaching that has been provided. Okay, so let's take a look at this question. Click to specify whether the statement indicates an understanding or no understanding of the teaching that's provided. I will use the call bell and wait for someone to help me get out of bed. All right. So if the patient has had a thrombolytic agent to dissolve a blood clot, then the patient is going to be at risk for bleeding. And therefore, we always want to prevent a fall. And so the nurse should always instruct the client to call someone for help. And therefore, this indicates an understanding. A speech and swallow test will determine if I can drink normal again. So you remember that whenever we have a stroke, it may cause dysphagia or difficulty in swallowing due to the impairment of the muscles of the mouth, the tongue, and any muscles that are involved with swallowing. And that is why we always have to have a swallow evaluation within 4 hours to 24 hours of a patient's admission. Now, what would it show? Well, the speech and swallow evaluation will determine if the client should have thin or thickened liquids or pureed foods in order to prevent aspiration. And thus, it's going to be a correct understanding of your instructions. I will switch to an electric razor instead of a straight razor to shave. Well, it is important that the client should take precautions to reduce bleeding, and switching to an electric razor or brushing their teeth even with a soft bristle toothbrush actually are interventions that has to be undertaken. And so therefore, this is a correct response. It's an understanding. All right. The physical therapist will determine my functional ability. Now, this is a little bit tricky because the client actually is going to have to be assessed as far as how much they can do for themselves, not only by the physical therapist, but also by the nurse. So the major responsibility for determining how much a patient can do for themselves is going to be something that the nurse has got to do. Okay. And so it's not only the physical therapist, but the nurse primarily. At discharge, I should plan to self-administer insulin for hyperglycemia. Now, is it necessary actually for the patient to have insulin at all times? And the answer to that is no. The object, however, is to maintain normal blood glucose in order to prevent complications that are going to be associated with hyperglycemia. So this one is not going to be understanding. Just because he had a stroke and had a thrombolytic agent doesn't mean to say that they're going to be receiving insulin for treatment. And then, of course, I will follow up with my gynecologist to determine a better contraceptive plan. Well, yes, the client should inquire about other alternatives to prevent pregnancy. And the reason is the combined hormonal contraception contains estrogen. And when we have estrogen, what happens is it influences blood clotting. Because if you don't know, estrogen influences fibrinogen in the plasma, specifically factor 7 and factor 10. And that is why it increases the risk of a stroke. And so this would be correct. The patient should be encouraged to talk to the physician, to her gynecologist or obstetrician, to prescribe alternative anticoagulant agents to prevent blood clots again, right? And by the way, that apixaban is going to be an oral anticoagulant that is going to be used to prevent blood clots and therefore prevent stroke. Okay, so that is the case study. And so what I'd like to do now is to go to our introduction, and then we will finish it. We will not finish it tonight, but we will continue tomorrow with whatever we do not finish. Okay, so I'm sorry for this. Okay. All right. So when we're talking about CVA or cerebrovascular accident, it is sometimes referred to as an ischemic stroke or a brain attack. This is going to be a sudden loss of brain function. And the reason why there's going to be loss of brain function is because there's a disruption of the blood supply to a part of the brain. Obviously, when you're not getting enough blood into an area, it results in death of tissue. And so, therefore, this is exactly what happens in CVA. Now, there's a big campaign to raise awareness as far as rapid assessment to determine if a patient is having a stroke. And I'm sure that you all have heard about FAST. And FAST says that any time that you suspect somebody that has a stroke, remember FAST. And this acronym will ask you to assess the face. So what are we going to do as far as the face is concerned? We're going to ask the person to smile. Is one side of the face drooping? If it is, then that means to say that it leads to the possibility that the patient is experiencing a stroke. The A stands for the arms. We ask the person to raise their arms. So you should be able to bilaterally raise your hands. If one is weaker and it goes down, for example, then that means to say that there is a high possibility that this patient is experiencing a stroke. And then S is for speech. We ask the patient to speak. If the speech is slurred, then again, it points to the possibility of a stroke. And then, of course, time. We always want to make sure and emphasize that the first sign of a stroke, the patient should access the emergency medical system by calling 911. Here's the algorithm that's proposed by the American Heart Association, and we're going to examine each of these algorithms so that we understand what the responsibilities are as far as stroke is concerned. So before we go there, let's identify the types of strokes that there are. There are two types of stroke, as I said earlier. One is what is called ischemic, and the other one is hemorrhagic. Both result in depletion of oxygen to areas of the brain. So what is this ischemic stroke? Oh, what happened over here? Hold on one moment. Okay, see. Yeah. All right. So what happens in a ischemic stroke is that there is something that interrupts the blood supply to an area. So let's say that this is the brain, but there's going to be narrowing of an artery over here, or maybe a blood clot. So that means to say that blood can no longer go through to this area. It results into the death distal to this obstruction. This describes what happens in a ischemic stroke. So this is the most common type of stroke. 75% of all strokes are going to be ischemic in nature. Now, cryptogenic stroke means to say that we do not know what caused the stroke. And so this is 30% of the causes of stroke. So in some or 75% of the cases, it's due to a thrombus, but in some it's cryptogenic, or we have an undetermined reason why the patient has a stroke. Now, the causes of ischemic stroke, and the most common is going to be atrial fibrillation, untreated atrial fibrillation. And the reason why untreated atrial fibrillation is going to be the cause is because when the atria does not contract very well, what happens is that it throws or develops emboli. Okay, so we have two atria. One is in the right side, the right atrium, and the other one is in the left atrium. And the left atrium actually has an appendage. So it looks like this, okay? And so whenever the heart is not pumping correctly, what happens then is it's going to most likely result in formation of blood clots in the left atrium, not in the right atrium, because of the presence, again, of this thing right here. So if the patient's atria is not pumping correctly, blood clots will develop over here on the left atrial appendage. And that's the reason why when patients have atrial fib, they do not have like a pulmonary emboli, but rather the number one complication is going to be a stroke because the left atrium is where the blood clots are going to develop. So if the left atrium is where the blood clot develops, the blood clot will go into the left ventricle, and after the left ventricle into the aorta. And as we know, the first branch of the aorta are your carotid arteries. And that is the reason why most of the time, whenever you have a blood clot from the left atrium, it's going to migrate or go to the brain. Okay, so please understand that because they're going to ask you in NCLEX, where is the emboli likely to form in atrial fibrillation? And the answer to that is it's going to be in the left atrial appendage. And that's the reason why it is most likely going to cause a stroke. Okay? So the other things that would cause it are arthritis and a patent foramen ovale. Again, this is a congenital heart defect, as well as left ventricular dysfunction and septic shock could also precipitate the development of ischemic stroke. And sometimes the symptoms of stroke begins with a mild or a precursor to stroke. And this is what's known as a transient ischemic attack or TIA. And we'll talk more about TIA in a little bit. The other kind of stroke is hemorrhagic stroke. And hemorrhagic stroke is going to be much more, it's different from the pathophysiology of an ischemic stroke. So it occurs when the areas of the cerebral artery become weak or thin due to a long-term or acute episodes of hypertension, which leads to an outpouching of the blood vessel, and this is what is known as an aneurysm. So hypertension will cause the weakening of the blood vessels, and sometimes when the blood vessel becomes weak, it is going to outpouch like that, and the pouching is what is known as an aneurysm. So when you have high blood pressure and this ruptures, therefore, it's going to cause bleeding within the brain. So intracerebral hemorrhages are typically caused by ruptures of the vessels due to damage as a result of hypertension. All right. So I told you that ischemic stroke may be preceded by transient ischemic attacks. So it is known as TIA. So what is TIA? Transient means to say every now and then. Ischemic meaning to say that we're going to have a lack of oxygen in an area. And attack means to say that's episodic. It doesn't occur all the time. So a TIA, therefore, occurs when there's a temporary occlusion or a blockage of blood flow to a portion of the brain. And this transient occlusion can cause symptoms that might mimic a stroke. And what might be those symptoms? Well, it might be a slurred speech, visual disturbances, maybe weakness in an extremity, or even sometimes changes in the level of consciousness. However, the main difference with TIA and a stroke is that it occurs or it disappears within 30 minutes. With stroke, the symptoms will last longer than 30 minutes. So this is what is known as a transient ischemic attack. When we examine these patients, what happens is that sometimes there's going to be what is known as amaurosis fugax right here. And this is a transient vision loss as a result of an occlusion or stenosis of the internal carotid artery. So when the internal carotid artery is blocked, it's going to lead to decreased perfusion in the ocular arterial circulation and therefore causes this transient vision loss. So basically, in these patients, the carotids are clogged and therefore the eyes aren't getting perfused and therefore it temporarily shuts off the light. That is why it's called amaurosis fugax, and that is one of the symptoms that is going to happen with a TIA. The other thing is that on physical examination, you can hear a carotid bruit. And a carotid bruit is when you listen to the carotid arteries and you hear a swishing sound. What you should hear when you put your stethoscope on the carotid arteries is lub, dub, similar to lung sounds. But in a patient with a narrowed carotid artery, so if this is the carotid artery and it's narrowed as a result of atherosclerosis, you're going to hear a swishing sound like psh, psh, psh. That is a carotid bruit. And that is therefore a manifestation that the blood vessel, the carotid artery, is narrowed. Okay? So that is going to be a significant finding as far as TIA or transient ischemic attack is concerned. And the diagnosis is going to be the same as a stroke. We're going to use MRI, CT scan, MRA, as well as CTA. And the treatment would include surgical treatments, and that would include removal of the plaque that is called carotid endarterectomy. And sometimes we would also put a stent in order to prevent the collapse or narrowing of this blood vessel. So that would be carotid endarterectomy with carotid artery stenting. Obviously, we could also prevent TIA by giving the patient anticoagulants as well as antiplatelets. So there's a difference between anticoagulants and antiplatelets. Antiplatelets are going to prevent the platelets from sticking together. And so examples of that would be aspirin as well as clopidogrel. And of course, we all know about the anticoagulants such as heparin, Coumadin, and so on. Okay. All right. So having talked about the two types of stroke and the symptom that occurs before a stroke, which is TIA, let's now take a look at the risk factors for the development of stroke. Now, there are modifiable risk factors. There's also non-modifiable risk factors. And so we're going to focus more on these modifiable risk factors. But the non-modifiable risk factors is that it's much more common in individuals that are older than 45. And also, it is going to be much more common in women, all right? Current American Heart Association research reveals that women between the ages of 55 to 75 have a higher risk of having a stroke compared to men. All right. Now, the other things is that race. As far as race is concerned, Black, Hispanic, or Asian ethnicity, all these ethnic groups are going to have higher incidences of stroke. So let's now go to the modifiable risk factors. As far as the modifiable risk factors, we know that we can control hypertension. And so that's one of them. We could also prevent the complications associated with atrial fibrillation. So anybody who has atrial fibrillation must always be on an anticoagulant. So that is the reason why it's modifiable, because it could actually prevent the formation of blood clots. Hyperlipidemia, obesity, smoking, diabetes, and so on are all going to be risk factors as well. Now, I must also add alcohol and drug abuse. Now, I've talked a little bit about alcohol earlier, but we did not talk about drug abuse. There's going to be a higher risk for individuals that are users of drugs such as cocaine, heroin, or even PCP. All these things could increase the risk of all types of stroke. They even say that actually the use of cannabis or marijuana actually also increases the risk of a stroke. Then again, I want to make sure that I mention again that alcohol, you remember, it follows a weird pattern in that the risk is related to the amount of alcohol that's consumed daily. So if you drink less than 1 drink per day for women and 2 drinks per day for men, it reduces actually the risk for stroke. But if you go beyond that, then it's going to increase the risk. So let me just write that down so that you will remember it. So as far as alcohol is concerned, for women, 1 per day is going to be okay. For men, 2 per day, 2 drinks per day is going to be okay. So this is going to be protective. It actually prevents stroke. All right. All right. If you also notice that there is a modifiable risk factor here, and that is periodontal disease. Now, uh, in teaching my class to the 600 some nurses that are international, they asked me, how could it be that periodontal disease can cause a stroke? Well, you remember that there is going to be a close proximity of the oral cavity and the brain. And therefore, if an infection rises to the brain, then what could happen, therefore, is it could cause either meningitis or it could also cause stroke. So those are actually also risk factors. Okay, let's go to this question. Okay, so let's take a look at over here. A patient is admitted with uncontrolled atrial fibrillation. What type of stroke is he at most risk for? All right. So whenever we're looking at these words over here, we need to make sure that we understand what's happening. Thrombosis is when, I'm going to illustrate that. So if this is a blood vessel and atherosclerosis is going to block it, this is what's called thrombosis. Okay. Embolism means to say that there is this blood vessel and a blood clot is going to occlude the lumen of the artery. That's an embolism. And then, of course, hemorrhagic would be when a outpouching of the walls are going to break, and it would cause a hemorrhage. And ischemic stenosis, this is something that is a, what do you call that, there to confuse you. But anyway, the two main possibilities is thrombosis or embolism. And the correct answer here is letter B. It is an emboli because the blood clot travels from the heart to the coronary, I mean, to the cerebral arteries, which therefore causes the stroke. Okay? All right, very good. So in this particular question, we're asked about the risk factors, and we know Black ethnicity, female, hypertension, diabetes are all known risk factors for the development of stroke. So the hypertension is going to be significant over here. History of rheumatoid arthritis and the use of steroids are not noted to predispose anyone for stroke. All right, so the answer here is you're correct. It's letter C. And the reason why that is, we had already said that a hemorrhagic stroke occurs when bleeding in the brain happens because of a rupture of a blood vessel. And the risk factors for hemorrhagic stroke, the most important one is going to be uncontrolled hypertension, and also if they already have a brain aneurysm. So those are some of the things that would cause an hemorrhagic stroke. So let's go to the pathophysiology of stroke. So whenever there is occlusion of the vascular bed of the blood vessel, obviously there will be a decrease in cerebral blood flow. And what happens is that there's not going to be enough oxygen and glucose that would feed the tissues of the brain. So there's no cellular metabolism, and the energy producing processes are going to be stopped. And therefore, it results in necrosis or death of a tissue. Apoptosis means to say that the cells that are missing the oxygen as well as glucose will now rupture like a suicide. And therefore, that's called apoptosis. And both necrosis and apoptosis will cause inflammatory processes. So what do I want to emphasize over here? I want to emphasize that with the blockage of the vascular or the blood vessel, there's going to be lack of metabolism, and the lack of metabolism will cause the brain to swell. And therefore, the signs and symptoms of brain swelling are going to be noted anytime you have a stroke. Now, because the blood vessels are the ones that are going to carry the problem in stroke, we need to now look at the major arteries that are going to be involved in a stroke. So the brain receives blood from the left and the right internal carotid arteries. So that's the left and the right internal carotid arteries, as well as from the back, the left and right vertebral arteries. They come together and they form what is known as your basilar artery. Okay? So these are the things that are going to be majorly affected. So whenever we have an anterior cerebral artery stroke, which means to say that it's the anterior cerebral artery that's going to be affected, it will manifest itself by paralysis of the foot and leg in the opposite area. But the one that's most important is this one. This is a common question in NCLEX. If the middle cerebral artery is going to be affected, what is going to happen? It will also cause paralysis in the opposite arm and the face, but also aphasia. So anytime you have speech disorders, then it's going to be most possibly as a result of occlusion of the MCA or the middle cerebral artery. So I want you to remember that. The middle cerebral artery stroke is the one that causes aphasia. The other thing that is going to be important is the posterior cerebral artery. Whenever you have occlusion of the posterior cerebral artery, it's going to cause hemianopia. And homonymous hemianopia is a visual disturbance wherein the patient is going to be blind in one field. Okay, so we'll talk more about what that is in a little bit or later on, as well as alexia without agraphia. So agraphia is the loss of the ability to write. Alexia is when you are word blind. So you have lost the ability to read. Okay? All right, so those are the important things as far as the slide is concerned. The middle cerebral artery causes, if it's occluded, will cause aphasia. The posterior cerebral artery is going to be occluded. It will cause hemianopia or visual disturbances, as well as alexia without agraphia. And again, alexia means to say that you lose the ability to read. Agraphia is loss of the ability to write. Okay, so those are the blood vessels I want you to remember. The middle cerebral artery. Any occlusion or stroke of the middle cerebral artery will result in aphasia. The posterior cerebral artery, whenever there is stroke, it will result in visual disturbances, in particular, homonymous hemianopia. And lastly, it's going to cause alexia, meaning to say they lose the ability to read. They can write, but they cannot read. Okay? All right. So because it depends on the area of the brain that is involved, it is therefore important to talk about the brain function and the anatomy, because depending on the area of the brain that's involved will also manifest differently. So the brain is divided into three main areas: the cerebrum, which includes your right and left hemisphere. And of course, the cerebellum, this is the top and the front of the brain, as you could see right over here. And then, of course, the brainstem. And the brainstem and the medulla right over here are going to be the ones that connects to the spinal cord. So the brainstem plays a vital role in functions like maintenance of heart rate, blood pressure, breathing, GI function, and consciousness. The cerebrum, on the other hand, are the ones that makes us intelligent. So it includes movement and sensation, speech and language, eating, and so on, emotional control, sexual ability. The cerebellum are mainly for coordination. It helps with muscle coordination and balance. So I always want to think of the cerebrum as those that make us intelligent. So remember that. So speech, dogs, for example, cannot talk. They don't have language like we do, and so on. The cerebellum is important for coordination, and then your brainstem is going to be for life. So those things that make us breathe, for example, the things that make us have a normal heart rate or respiratory rate, all those things are going to be the functions of the brainstem. Okay, so again, there are several lobes in the brain and the cerebrum. It's divided into four lobes. So if we were looking at the cerebrum right over here, we could divide this into four lobes. And these lobes are going to be your frontal lobe. And what I want you to remember in frontal lobe is that it controls movement and also executive function, which is our ability to make decisions. So okay, over here, the frontal lobe is movement and decision making. The parietal lobe, right over here, is the part of the cerebrum that is going to process sensory information. So it lets us locate exactly where we are physically and guides movement in a three-dimensional space. So it includes touch and perception, as well as body orientation and sensory discrimination. Like, for example, I know that I'm sitting on a chair in my home office. That's a function of the parietal lobe. Now let's go to the temporal lobe. The temporal lobe plays a vital role in hearing, in smell, in memory, as well as visual recognition of faces and language. So this one is where you hear your language as well as your memory. And then, of course, the occipital lobe. The occipital lobe is primarily going to be one that is involved with vision. So I always remember occipital lobe with ophthalmology. And that is the one way that I am going to remember that this lobe is the one that is responsible for vision. The reason I'm sharing this with you is in NCLEX, it always asks you questions pertaining to the area of the brain that's most likely affected. So let's take an example of that particular question. Okay, so the correct answer is letter D, the temporal lobe. I have weird ways to memorize things, and I always remember the temporal lobe as tympanic, and the tympanic is going to be associated with the ears, right? And so therefore, that's the way that I remember it. And then, of course, occipital lobe will be associated with ophthalmology, and therefore the eyes. Okay, maybe that will help you, maybe it won't. But anyway, that's how I remember it. Okay, let's take a look at this question. Okay, I hope my clue helped. The correct answer is letter D. The occipital lobe is responsible for vision. And in addition to that, by the way, the occipital lobe is also responsible for color perception. All right, let's do one more. Okay, so over here, a patient's MRI imaging shows damage to the cerebellum. And I always think of bell whenever I think of the cerebellum. So bell has to be balanced in order to ring it. So that's the way that I remember it. So balance impairment is going to be the correct answer. It's important for coordination as well as balance. All right. Now, when you're looking at the brain from the top, there's going to be a left and right hemisphere. You could divide them into the left side and into the right side. And the thing that is going to be important here is that if the uh, stroke occurred in this area, it will have different kinds of manifestations as when it occurs on the right side. So we call these the left hemispheric brain, I mean stroke, or the right hemispheric stroke. So there are many, many questions that are pertaining to this particular um, concept that you have to remember about the hemispheres of the brain. So let's take a look at the hemispheres of the brain, the right and the left side. Okay. So whenever you're thinking of the right side of the brain, these are the ones that are going to be focused on attention span, emotions, decision making, memory, music, art. It's too much to remember. Okay. And so I'll give you a clue on the easiest way to remember that. But anyway, on the left side, this is the logical side. It is involved with speaking, writing, reading, math skills, analyzing information, and planning. So when you have damage on the right side, it is going to be different from when you have damage on the left hemisphere. So what I'd like for you to remember is this. You're going to write hyper over here, and over here would be slow, okay? And the reason why I want you to remember right-sided stroke by writing hyper with a capital R and slow for left with a capital L is because of the following. So let's take a look at the right side. Whenever there is going to be right-sided stroke or hemispheric stroke, what's going to happen is that the weakness that's going to be manifest is opposite that area. So you will have a left side weakness and a left side neglect. So what this means, therefore, is they're going to ask you, a patient with a right hemispheric stroke is admitted, where would you put his urinal? All right. So in this particular instance, because the patient's left side is going to be weak, you certainly have to position um, the bedpan or the urinal on the right side of the patient. All right. So the other things that are going to happen with patients with right-sided stroke or right hemispheric stroke is this. And that's the reason why I have the hyper right over here. They're going to have a poor decision making. They're going to be having a lack of concern. They're going to be impulsive. They're going to be inappropriate. And they might also experience depression. So those are your manifestations of a right-sided, right hemispheric stroke. For a left hemispheric stroke, the right side is going to be the one that will have hemiplegia, and they will have aphasia, agraphia, and apraxia. And I said again, apraxia is when aphasia, you know that, right? Agraphia is the loss of the ability to write. And apraxia is the person no longer knows anything that they knew in the past. Like, for example, when we itch, we scratch the area that is itching. When we feel pressure on our leg, we lift our leg, and so on. But in individuals who have apraxia, they forget all those functions. And therefore, this is going to be something that is going to be experienced by these patients. All right, the other thing is that they're going to have visual problems as well as depression, cautiousness, and hesitancy, as well as memory problems. So let's take a look at how NCLEX would address this. Who is going to be more at risk for a fall over here? A right hemispheric stroke or a left hemispheric stroke? You can answer in the chat box. Who is more likely to fall or have a higher risk for fall? Remember, the left is slow, they don't move. The right is hyper. Remember, they keep on moving. And so the correct answer is the right hemispheric stroke. Okay? Who is most likely to develop pressure ulcers? Who is going to develop pressure ulcers more likely? Okay, the left side, because they do not move. You remember? The other one is hyper, they're going to fall. The other one does not move. So you have had patients, I don't know if you've ever experienced taking care of stroke patients, but you have patients who have stroke and they are lying in the bed all the time in the same position. They don't move at all. That's a left hemispheric stroke. The one that is restless, trying to get out of bed, is always going to be the right side. They're hyper. All right. Who's going to be talkative? Talkative. They're going to be talking like crazy. Right hemispheric or left hemispheric? Right. Okay. Because the left, you remember they're slow, they don't talk. So that's the reason why they have apraxia. This is where the Broca's area and the Wernicke's area are located in the left hemisphere. So therefore, it's going to affect their ability to speak and also to anything that is associated with language. Okay, good. All right. So, in summary, the right brain damage, when you have a right hemispheric stroke, you have paralysis on the left side, you have left side neglect, you're going to have spatial perceptual deficits, and that's why they are at risk for falls. They tend to deny or minimize the problems, rapid performance, short attention span, they're impulsive, which requires you to have safety problems because they have impairment of judgment and impaired time concepts. For the left hemispheric stroke, the hemiplegia is on the opposite side, the right side. Language is where the left side is located. So anything that relates to language will be experienced by somebody with a left hemispheric stroke. And then, of course, they're slow in their performance, they're cautious, they're depressed, and they have impaired comprehension related to language and to math. So that's the easiest way for you to remember. Hyper for right and slow with an L for left hemispheric stroke. Okay, so we had talked about the left hemisphere containing the speech area. And so we're going to talk about the types of speech problems of a stroke, after a stroke. When a stroke affects speech, it is often a result of a left hemispheric stroke. This is because, again, the language center of the brain resides in the left hemisphere. And there are two main areas of the brain that is associated with language. And the first one is the Broca's area. And the Broca's area is the one that is associated with producing language. So the muscles that tries to create the speech is a function of the Broca's area. The Wernicke's area is the one that is responsible for understanding or comprehending the language. Okay? So whenever we have damage in the Broca's area, we usually will have expressive aphasia. But does the patient know what they want to say? And the answer to that is yes. So patient knows what to say, but can't say it. All right. So when you're talking to a patient with Broca's aphasia, there's going to be expressive aphasia. So expressive aphasia is also known as Broca's aphasia. They have difficulty with spoken as well as written expression. Now, the other one is Wernicke's area. And the Wernicke's area is going to be the one that is going to be associated with comprehending language. And so when we have Wernicke's area, then what's going to happen is that we are going to be fluent, but we do not make any sense. So we can talk, but no sense. So in a patient with Wernicke's aphasia, you're going to ask them, are you having pain? And the patient will say, I already ate. So they can talk, but there's no association with what was received. In patients with Broca's aphasia, you ask them, are you having pain? And the patient will say, oh, they know what to say, but they do not have the ability to phonate or to say exactly what they want to say. Okay? So those are the two types of aphasia that I want you to remember. Expressive aphasia, also known as Broca's aphasia, and then, of course, the receptive aphasia or fluent aphasia, which is known as your Wernicke's or fluent aphasia. There could obviously be a possibility that both of them could be affected. And so when both of them are going to be affected, we call this global aphasia. Difficulty with speech production, with expression, as well as understanding or comprehension. Okay, let's apply that to a question right over here. Great. I think you're understanding it very well. So when they have right-sided brain damage or right hemispheric stroke, what's going to happen is that they will have weakness on the contralateral side, so on the left side. So letter D would be correct. They will have left unilateral neglect. Uh, they're also going to have what else? They're going to be hyperactive, so they're going to be impulsive with a short attention span. Letter A is incorrect because it should be the left side. They could have confusion also as a result of a right hemispheric stroke. The things that are related to language are all going to be left hemispheric stroke. So I'm glad that you got that correctly. Let's go to another one. I'm excited that you're getting it good, well, very well, excellent. So this is a left hemispheric stroke. So remember, slow is going to be your key. So are they going to have aphasia and agraphia? So this is language. You remember they're slow and therefore A is the correct response. Denial, this is going to be the right hemispheric stroke. You remember they're impulsive and they deny their limitations, and that's why we have safety concerns about these patients. Are they going to have issues with math skills? Yes. You remember, and then issues with seeing on the right side? Correct. This is contralateral to the left side, and as well as depression and anger. So A, C, D, and E are all correct responses. All right, so I think this is a good place for us to stop tonight. because tomorrow what we're going to do is to look at the algorithm, and we're going to look at implementations as far as stroke is concerned. Okay, so if you have any questions, please feel free to ask them now. You can chat it, or you could unmute yourself and ask it. But anyway, we will do part 2 tomorrow as far as the interventions and um, nursing interventions for patients with a stroke. Okay? So I'm glad that you were able to join us again, and thank you so much for your participation. Hope to see you tomorrow. Okay? Have a great evening. Bye-bye. Wonderful, Marie. Thank you.